Hello, my name is Quentin Broussard. I'm an assistant professor of clinical sciences at Keck Graduate Institute, and today we will be discussing nutrition and critical care and the consensus and controversy related to recommendations related to nutrition and critical care. The reason we're talking about this topic today is that critically ill patients represent a specific subset of nutrition support patients who also have specialized nutrition requirements in regards to macronutrient and micronutrient allotment. As a result of this, as a pharmacist, it's important to be aware of the key differences and similarities that critically ill patients have to other patient populations and be able to allot nutrition support regimens that will meet the needs of our critically ill patients. Our objectives today will be to identify potential nutrition assessment markers in the intensive care unit with emphasis on albumin, prealbumin, and CRP, to determine macronutrient and micronutrient requirements in critically ill patients, and to discuss nutrition support challenges in specialized critically ill patient populations. So the concept for this talk basically started back in 2009, when the guidelines for the provision of and assessment of nutrition support therapy in the adult critically ill patient came out. And these are published by the Society of Critical Care Medicine and the American Society for Parenteral and Enteral Nutrition, or ASPEN, which is essentially the society that publishes a lot of the nutrition support guidelines and data that we have. In regards to this guideline is a little bit outdated and is almost at this point a decade old, as you can see here. This changed back in Austin, Texas, during Clinical Nutrition Week 2016, which is the conference that Aspen hosts annually to basically review new advances within the nutrition support area. These have a wide variety of different authors. You have physicians on this guideline, you have registered dietitians, PhDs, as well as pharmacists. You'll actually see some pharmacists on this guideline, which is actually pretty pleasant to see. As a pharmacist myself. So what is in these 2016 guidelines? These guidelines cover things such as nutritional risk assessment, protein and fat requirements for critically ill patient, gastric residual volumes, and basically recommendations regarding those, immunonutrition, adjuvant probiotics, or essentially more or less what you do in regards to intensive care unit patients in regards to probiotics, surgical population subsets, so basically different surgery populations that are critically ill, as well as special populations, which we'll talk about today. So our focus today will be to talk about within this guideline, as the guideline is relatively large, will be to talk about nutritional risk assessment, protein and fat requirements of our critically ill patient, as well as special populations. We won't focus on gastric residual volumes, as we talked previously whenever we talked about enteral nutrition, that gastric residual volumes are no longer recommended. And this is the guideline that actually made that recommendation based off of a study that was published in 2013 by Renier and colleagues. So the first thing we'll talk about is nutritional assessment markers. The main nutritional assessment markers we're going to focus on are albumin, prealbumin, or PAB, and C-reactive protein, or CRP. And remember that in a lot of cases, these markers are not validated in a majority of patients, particularly if their CRP is elevated. So in inflammation settings, you will have most likely a non-reliable albumin and prealbumin whenever you're looking at it in regards to nutrition assessment. and assessing a patient's nutritional status. So these markers are also not validated in critical care patients. If we think about critical care patients, a lot of these patients have some kind of inflammatory process going on. And as a result of that, basically a lot of these patients will have a baseline CRP that is elevated. So these nutrition assessment markers are not recommended in 2009 or 2016 guidelines. And related to the pathophys, essentially there's just an acute phase response that increases vascular permeability and a reprioritization of protein synthesis. Basically, a lot of times what happens in critically ill patients is a lot of times protein will break down, so proteolysis will occur, and that will result in the breakdown of albumin and prealbumin. So, not even just in relation to inflammation, albumin and prealbumin are breaking down. And while they may result in lower serum levels, it doesn't necessarily mean a patient is malnourished. You have to look at, obviously, other markers of nutritional assessment to make that judgment. In relation to this finding in the guidelines, there are a few articles that are cited. One is this article from 2012 that looked at prealbumin and CRP levels taken at different time points and at different levels of caloric intake, and the trends were analyzed. So in regards to the overall trends, and this slide looks relatively busy, I understand. What I want you to focus on is essentially more or less the trends that you see in these boxes. So basically what you see in each of these different groups is that more or less over time that there is basically no clear correlation with calorie and protein allotment compared to what your prealbumin level is. For example, here in this blue box that you see, this first blue box, you see that calories increase and protein increases. However, that doesn't necessarily have a direct effect on your prealbumin here. It does have an effect potentially related to your CRP or associated with your CRP, but it's not necessarily a direct correlation. As you see here in this second group, the higher the calories and the protein, the higher your prealbumin goes in this case, but your CRP kind of goes a little bit all over the place. It goes from 82.8 to 58.1 to 60.2. Not really a clear correlation here. So essentially what from this study is that prealbumin is not an accurate marker for nutrition support in critically ill patients in the presence of inflammation. And obviously, clinical judgment should be used to determine nutritional adequacy. So obviously, looking at other markers such as weight loss, for example, body mass index, any kind of dietary intake history that you have on your patient might be important to actually assess your patient, as well as your typical physical exam findings. So if you see patients who have pre-existing muscle wasting or fat wasting, that might be obviously a concern. In results to Anthropometrics, these are, as you remember from our first talk regarding nutritional assessments, are measurements of the human individual. However, in typical fashion, these are not reliable in nutrition assessment for the most part, outside of height and weight. Whenever you're measuring things like head circumference, waist circumference, etc., these can be a little bit subjective in the way that you actually measure them, as well as they don't really have a clear correlation to actual nutritional status in a lot of cases. And in critically ill patients, it is very important, as you realize that in critically ill patients, there's some kind of injury, infection, or inflammation that's going on. And that is basically leading to or related to cytokine production and obviously altered hepatic protein synthesis, which can obviously change the amount of muscle stores that you actually have related to your patient. Obviously, it may not necessarily be a thing that correlates to direct malnutrition, But in some cases it might, depending on the degree of what is actually happening with your patient. There are also newer assessment markers that are used to potentially assess nutritional status in patients. Some of these include calcitonin, pro-inflammatory mediators like interleukin 1 and 6 and TNF alpha, citrulline, which can be used as a potential measurement of gut function. CT scans can potentially be used to assess nutritional status, as well as ultrasound, and that's the one that we'll focus on here. With ultrasound, one new advent of ultrasound is that they can actually use ultrasound outside of the traditional uses of ultrasound, which we would think potentially used maybe in pregnancy to basically look at the status of a fetus. You can actually use ultrasound in other ways as well. One way is you can actually measure the distances and depths of different parts of the body, particularly adipose tissue and muscle and tendons. This diagram just basically shows you one way that this can actually be used to measure the different depths up to the bone of your patient's actual tissue to determine what their nutritional status is. Now, this hasn't been really fished out very well. We're still kind of learning about this method of doing nutritional status assessment in regards to patients overall. But it does appear very promising in that you can essentially look at depths of different parts of tissue and potentially maybe compare them to some kind of normal eventually. Again, this is not very well sifted out, but essentially it may be the way of the future for potentially measuring nutritional status. So the next thing we'll talk about regarding critically ill patients is macronutrient requirement. In regards to macronutrient requirements, as we know, protein is the most important macronutrient for obviously healing wounds, supporting immune function, and maintaining lean body muscle mass. And in critically ill patients, that's very, very important because in critically ill patients, patients may be in a bed for prolonged periods of time, days to weeks to even months, and sometimes even years. And in those cases, if you think about the concept of muscle builders, how they build up muscle, they are constantly making sure that they maintain a consistent exercise regimen daily or at least on a regular basis, such that their muscles are being maintained. If those muscle builders stop using their muscle, you lose it. And basically that muscle basically goes away. It's the same concept in critically ill patients. If they don't use muscle, they lose muscle. And in cases of critically ill patients and patients who are hospitalized, that can be up to 1 kilogram per day of actual body weight that is lost. It may not necessarily be that amount every single day for every single patient, but a significant amount of muscle is lost just sitting in a hospital bed, not moving around very much. As a result, the guidelines for critical care nutrition, published by Aspen and SCCM, recommend 1.2 to 2 grams per kilo per day be given to patients who are critically ill. And this is obviously due to the fact that the patients are very inflammatory in nature and obviously that they are not moving around very much as well. So obviously, it's not just about the protein requirements here, but it's also important to early mobilize your patients when possible, because early mobilization will obviously help preserve that lean body muscle mass that patients can then use to then go and do other bodily functions and other activities of daily living. So it's not just a thing about giving adequate amount of protein, it's a thing about getting them to exercise and move around. Because you can give them adequate amounts of protein, but unless you get them to move, it's not going to matter. You need to basically get them moving if you can. In patients that were critically ill and had trauma, Roland Dickerson and colleagues actually did a study that was published in 2012 evaluating 249 patients with critical illness and trauma and evaluating their nitrogen balance based on protein intake. And just to kind of refresh memory on what nitrogen balance is nitrogen intake minus urinary urea nitrogen divided by 0.85 minus 2. For the purposes of exam purposes, I'm not going to have you know this formula. I just want you to keep that in the back of your mind that essentially protein intake is associated with nitrogen intake. What Roland Dickerson and colleagues found was that as protein intake increased in critically ill and trauma patients, basically your nitrogen balance got closer to zero. And you saw that nitrogen balance approached near zero, which is essentially our goal in most patients is to get as close to that zero as possible, because that basically represents a balance between energy gained and energy lost, or energy consumed and energy used, more or less. So what this study essentially found based off this schematic here is that increased protein led to better nitrogen balance, which could potentially lead to good outcomes for your patient. The next macronutrient we'll talk about is fat. So one common method that we use to actually give patients their fat requirements is intravenous fat emulsion, particularly with parenteral nutrition. Intravenous fat emulsion contains omega-3 and omega-6 fatty acids, and those are known as alpha-linolenic acid and linoleic acid, respectively. And these fatty acids help prevent essential fatty acid deficiency, or EFAD. So essentially, and no pun intended here, these fatty acids are needed in the diet that basically, correlating to the word essential here, these fatty acids are essential in the diet for us to take in because our body does not actually make these fatty acids, omega-3s and omega-6s, the alpha-linolenic and the linoleic acid. One debate that pops up in critical care is should IV fat emulsion be given during the first week of ICU stay. And Battistella and colleagues looked at this in a 1997 randomized controlled trial looking at polytrauma patients receiving PN. They looked at standard fat emulsion versus having fat emulsion withheld for the first 10 days of PN therapy. And they looked at patients in the comparator groups having basically the same amino acid and carbohydrate doses received. Whenever they compared the groups, they actually found that the lipid group was statistically significantly different than the no lipid group, as we see here with the p-values all less than 0.05. We saw that lipids in this study correlated to a higher degree of hospital length of stay, ICU, or intensive care unit length of stay, and days requiring mechanical ventilation. If we look further at their findings here, we actually see that there is a higher incidence of pneumonia and line sepsis with patients who got lipid versus no lipid. And I do realize that the 0.05, that number is not statistically significant, but a 27% versus a 14% when comparing lipid to no lipid may actually be clinically significant whenever you look at those numbers. Overall, there were more total infectious complications in the lipid group than the non-lipid group, which is important to note in this Battistella and colleagues study that was in 1997. When we actually look at fat emulsion in another study by McCowan and colleagues, we actually see that the patients in this study who received fat emulsion, their confidence interval actually crossed 1 whenever looking at outcomes. And basically, because their confidence interval crossed 1 here, basically that means that there was no difference between giving lipids and not giving lipids, which essentially pushed the aggregate result, ironically, whenever you're looking at both studies, to the right, where it favors without lipids. Though you see both studies here basically had a confidence interval that crossed 1, meaning that statistically they weren't significant. Though the aggregate actually produced a confidence interval that did not include 1. So basically the recommendation here is that current guidelines suggest withholding or limiting soy-based fat emulsion during the first week following initiation of parenteral nutrition in critically ill patients. The evidence here is very low, given the fact that these patients basically had those conflicting confidence intervals in both of the studies. And alternative IV fat emulsion products can be considered for use in these patients, such as Small-Lipid, which has a much lower quantity of actual soy-based fat in it. Remember, Small-Lipid contains soy, MCT, olive oil, and fish oil. The next thing we'll take a look at is calorie requirements for patients. And calorie requirements, as we know, are determined by indirect calorimetry, weight-based equations, and predictive equations. In regards to indirect calorimetry, we've noted indirect calorimetry as the gold standard in terms of assessing calorie requirements in patients. And essentially the reason why this is because indirect calorimetry measures carbon dioxide exchange and oxygen exchange that occurs in the body. And remember that macronutrients are broken down into carbon dioxide and water by a process called combustion, which is a chemical process. And because basically you have breakdown into carbon dioxide of macronutrients, that the carbon dioxide actually has to get eliminated through the respiratory tract and exhaled out of the body. So basically this equation here actually governs energy expenditure, or is equivalent to energy expenditure. This formula is not a formula you need to know off the top of your head for any exam, but it's just important to know basically the back concept of there is a formula involving oxygen and carbon dioxide exchange. Indirect calorimetry is typically used when predictive equations are inaccurate. There's a failure to respond to nutrition support, and and especially whenever there are specific metabolic or respiratory derangements in critically ill patients. Some technical expertise is actually required to operate the actual machine, and because it is expensive, it is limited in its use overall, though it is the gold standard in actually measuring the most accurate of calorie requirements in patients. This is what the machine essentially looks like. This is just one form of the machine. Essentially, the concept is that you basically strap a patient to some type of mask, and that mask is essentially connected to this machine here. This machine will then measure the patient's oxygen and carbon dioxide exchange over a certain period of time, to where it essentially is at steady state. And this can take, a short amount of time to achieve steady state, but the study may take upwards of an hour to complete. In regards to indirect calorimetry, it does have, obviously, we said its pros and its cons. It does, obviously assess calorie needs very accurately, but these machines, while this one looks relatively simple, there are larger machines that are a little bit more complicated and may be more expensive to actually use and operate. There are some limitations to indirect calorimetry and certain patients where you cannot use indirect calorimetry. These include patients who do not have adequate oxygen and carbon dioxide exchange. And basically, if you look at each of these different criteria, that would actually be a reason why a patient may not necessarily be indicated for indirect calorimetry. So if their FiO2 or fraction of inspired oxygen is above 50%, and usually a patient will have to be on a ventilator or some type of respiratory support to have that high of an FiO2. Our normal FiO2 in our atmosphere is 21% because we have 21% oxygen in our atmosphere. And FiO2 of 50 is much higher than that. If you have a positive end expiratory pressure of at least 10 or more, that is also a reason not to use indirect calorimetry. At that point, these patients are very respiratory compromised, and as a result, indirect calorimetry may not be best to use for these patients. If you have an elevated respiratory rate above 30, if you have stressors such as elevated heart rate, or a mean arterial pressure less than 60, where you're not perfusing enough in general to get adequate oxygen and carbon dioxide exchange. If you have agitation, that is also another indicator that indirect calorimetry may not or should not be used. If you have continuous hemodialysis like CRRT, for example, or if your patient is within 3 hours of intermittent hemodialysis, that might be an indication not to use indirect calorimetry because essentially these dialysis machines pull off blood. If your hemoglobin is less than 8, that might indicate potential problems with oxygen carbon dioxide exchange. If you're within 3 hours after transfusion of blood products, if you have air leak around basically the unit that's being used or within a chest tube or ventilator cuff, that's a problem. If you have use of a volumetric diffuse respirator or an oscillator where essentially this machine is being a little bit more aggressive in regards to ventilating a patient, that might not be the best patient to do indirect calorimetry on. And also if you have untreated pneumothorax, where essentially a patient has collapsed lung, that's not a great indication to do indirect calorimetry. Predictive equations can also be used in regards to hospitalized patients. Penn State, Aretin-Jones, and Schwinnemer can be potentially used, as well as many others. Some that are used in non-hospitalized patients are Harris, Benedict, and Mifflin, Mesejo. Again, these are not necessarily equations that you need to know off the top of your head for an exam purpose, but just examples provided to you here. In regards to what equation you should use, it's really debatable depending on your patient population. But in general, in a lot of different patient populations, you'll actually see that these equations are only as basically good as the science that basically back them up. Because remember, every patient is individual in nature, and everybody will have their own nutritional requirements. So when you compare these equations to indirect calorimetry, they may underpredict or overpredict your actual calorie requirements, just as regular weight-based equations will do as well. We just don't really make a big fuss about it, because essentially whenever you're comparing using a weight-based equation to a predictive equation, weight-based equations tend to be a little bit easier to use because they're easy to remember. Predictive equations, you have to obviously go through and do significant calculations. As we see here in this analysis that was done, these predictive equations may only be correct up to 60% to 2/3 of the time overall when compared to indirect calorimetry, which is pretty startling whenever you think about these equations. But I mean, that's essentially the reality of what we have available to us at this point. And that is why indirect calorimetry is the gold standard, because basically these predictive equations are no better in a lot of cases compared to weight-based equations. Indirect calorimetry, again, is the gold standard. So in terms of our weight-based equations now, in terms of critically ill patients require 25 to 30 kilocalories per kilo per day. However, that number doesn't apply to underweight or obese patients. In terms of obese patients, these patients require 11 to 14 kilocalories per kilo of actual body weight for BMI 30 to 50. And in regards to patients who have a BMI greater than 50, they should get 22 to 25 kilocalories per kilogram ideal body weight per the Critical Care Nutrition Guidelines published in 2016. And obviously, this may vary between different patient populations. So if you have other compelling indications to give a higher or lower, in some cases, protein or calorie count, you should obviously look at all compelling indications. A lot of times you may give the higher number. Now we're going to change gears a little bit and look at nutrition support and specialized critical care population. So the first one we're going to discuss is pulmonary failure. In regards to pulmonary failure, one question that pops up in the guidelines is optimal carbohydrate and fat ratio for patients with pulmonary failure. This pops up because in patients with pulmonary failure, obviously carbon dioxide is a major issue, and carbon dioxide is a byproduct essentially of macronutrient metabolism and breakdown. Whenever macronutrients are broken down, they produce, again, carbon dioxide and water as a result of combustion. And you see that in the Krebs cycle here. Carbon dioxide is basically produced. And that carbon dioxide essentially will leave the body through exhalation, through the lungs, and through the mouth. Now, whenever you take in too much food, obviously there are, cons to that. Particularly if you take in a lot of carbohydrates, because essentially those are the ones we typically think about in regards to carbon dioxide release particularly. But as you'll also see, they're also given off in fat, in basically your fatty acid metabolism and processes that go on within the body here. So as a result, carbohydrates and fat both give off carbon dioxide. But is there an optimal ratio of carbohydrate and fat that you should give to your patients that have pulmonary failure, given the concern over accumulation of CO2? A few studies looked at this. One small study by Alsati and colleagues of 20 patients looked at high fat feeds versus low fat feeds, and their outcome was time to extubation. Whenever you compared these patients in the Alsati study, basically the net outcome here was that there was a correlation between a lower time on the ventilator with high fat feeds versus lower fat standard feeds. So basically what they found was higher fat intake led to faster time to extubation. However, in a study done by Mesejo and colleagues, a study of about 50 patients where they also looked at a similar concept of high fat feeds versus low fat feeds, there was no difference in ICU length of stay, mechanical ventilation duration, and mortality. As you can see here via the p-values, nothing was really significantly different in terms of mortality, mechanical ventilation duration, or ICU length of stay. So what the guidelines say regarding this concept of high fat versus low fat feeds and basically high fat, low carb formulas is that these high fat, low carb formulas are not recommended in critically ill patients with pulmonary failure. And that includes basically formulas, for example, like Pulmacare or Oxepa. These formulas may not necessarily prove to be of benefit to those patients with pulmonary failure. Another concept that's important in pulmonary failure is phosphate allotment or serum phosphorus monitoring in pulmonary failure. Because if you think about patients who receive phosphate or phosphorus in the diet, basically phosphate leads to the building blocks of ATP. Because remember, you have essentially 3 phosphate groups here. And that ATP is essentially energy that can be used in cellular and organ function. In a study done by Alsumrain and colleagues, a 66-patient prospective study, they looked at basically phosphate trends in relation to mechanical ventilation. So basically what they did was they measured serum phosphorus levels around the time of extubation of patients. And what they saw here is whenever they looked at phosphorus in millimoles per liter, which is about 1/3 of actual milligrams per deciliter of serum phosphorus levels. So basically a 1 here on this scale will actually correlate to a 3.0 or around a 3.0 on milligrams per deciliter of phos, which is our typical normal units that we use for phos is milligrams per deciliter. So think of this as 3 here. In regards to that, basically a level above 3 basically correlated to a more successful attempt or more successful related attempt to extubate a patient, whereas low phosphate or phosphorus levels correlated to a failure to wean from mechanical ventilation. Now, it doesn't necessarily mean that all patients who have low phos will be unable to be extubated. That's not what I'm saying. I'm just saying that there's a correlation here. It doesn't necessarily mean that if you have an adequate phos level that you're going to be extubated. You have to obviously correct whatever the underlying cause of that respiratory failure is, whether it is sepsis, acute respiratory distress syndrome, COPD, exacerbation, etc. The next topic we'll talk about is renal failure. In critically ill patients who have renal failure, the guidelines suggest 1.2 to 2 grams per kilo per day and calorie requirements of 25 to 30 kilocalories per kilo per day in patients with acute kidney injury and renal failure within the intensive care unit. In patients who get continuous renal replacement therapy, because a lot of protein is lost, up to 10 to 15 grams of protein per day or more, patients who get continuous renal replacement may require up to 2.5 grams per kilo per day of protein. This also might be the case if they're getting daily hemodialysis or frequent hemodialysis, where it's essentially more than our typical Monday, Wednesday, Friday type schedule or 3-day schedule per week. In regards to hepatic failure, essentially these recommendations are essentially the same as we saw in the nutrition and liver disease PowerPoint. Basically, their recommendation here is you should avoid restricting protein in patients with hepatic encephalopathy because that is essentially compromising patients' nutritional status. And we want to make sure that we improve patients' nutritional status as much as possible, particularly if they are going for a liver transplant or if they have hepatic encephalopathy. We want to avoid restricting protein in both of those patient subsets of hepatic failure. In regards to sepsis, sepsis requirements are typically for protein 1 to 2 grams per kilo per day. And in sepsis patients, you can actually do something that's a little bit different than traditional practice. You can actually do what's called trophic feeding, trickle feeding, or permissive underfeeding of these patients during the initial phase of sepsis. If you think about septic shock, those patients will have basically hemodynamic statuses that are variable, and they may be shunting blood away from the bowel at that point. That can make enteral nutrition very intolerable or not tolerable for a patient. As a result, it may be beneficial to give lower amounts of enteral nutrition, such that you're still stimulating the gut and promoting immunity, but you're still giving a little bit of nutrition in the process so that whenever the patient's acute illness process actually resolves, then you can ramp up their feeding much easier versus having to basically start the process all after they are more or less in shock. Whenever they're in shock, it may be very difficult to actually feed the patient because of that blood shunting away from the gut and predisposing the patient to higher incidence of nausea and vomiting if being fed. So if you give them 10 to 20 mils per hour of enteral nutrition or 500 kilocalories per day, and there's also other variable definitions of this, that might actually be okay for the patient because essentially at this point in their sickness, they're probably in fight or flight mode. Whenever they go into rest or repose mode and they essentially are trying to heal from that injury process, that's whenever you want to really ramp up your nutrition. It might be later on in the process. Your goal, obviously, is to advance to goal as quickly as possible. And the goal for sepsis patients may be to advance to at least 80% of target energy over the first week. 80% is pretty good. That's still, a passing grade in a lot of cases. But you still want to try to get as close to that 100 as possible. In a study done by Robbie and colleagues called the PERMIT trial, they looked at a randomized controlled setup looking at permissive underfeeding versus standard feeding. About 33% of these patients had severe sepsis as per the old sepsis definitions. And their outcomes, they looked at mortality, mechanical ventilation, duration, length of stay, etc. Many different outcomes were in this study. The study was done in New England Journal of Medicine and was published in 2015. If you actually look at all of the outcomes that they have here, if you look at the p-values for the outcomes, you actually see that they are not statistically significant except for incidence of renal replacement therapy, which was actually higher incidence of dialysis in the standard feeding group, which it's kind of debatable about whether this is actually clinically significant or not. Yes, it is 11.4% versus 7.1%, and it is statistically significant. There were a lot of patients in this study, over 800 and close to 900. However, whenever you look at this, it's a little bit debatable in regards to the actual outcomes. The other thing you have to keep in mind in looking at the strengths and weaknesses of the study is what did they mean by permissive underfeeding and what did they mean by standard feeding. In this specific example, their permissive underfeeding group got around 500 calories, and their standard feeding group got probably around about 800 or 900 calories. So there might not necessarily be much of a difference in terms of that actual calorie amount between their groups, and that's probably potentially why you might have not seen not much different in terms of results here. But the main thing I just want you to keep in mind in terms of looking at this study is that though a lot of studies are flawed in some way, permissive underfeeding may be an option for some patients. So overall conclusions that we can draw from this presentation today are that basically in terms of prealbumin, CRP, and albumin, we basically have the same consensus that these do not basically work out. Indirect calorimetry is still the gold standard for measuring calorie requirements, but other methods can be considered like predictive equations and weight-based equations, though both of those may be potentially inaccurate. Protein administration should be optimized in most patient populations to improve outcomes, though the perfect number is still a little bit debatable as we still have a large range of more or less protein that can be given to patients who are critically ill. And trophic feeding may be considered in the initial stage of critical illness, not just sepsis. And this is a little bit still of a controversy where the jury is essentially still out on this particular finding. Here are the references for the talk today. If you have any questions regarding nutrition and critical care, please let me know. Thank you and have a great day.